Taking it forward, I will invite Dr. Saswati Sinha to give a talk on steroids and community-acquired pneumonia, who, when, and why. Dr. Saswati Sinha.
Good morning, everyone. I would like to begin by thanking Team Critic 2024 for the kind invitation. And the topic assigned is steroids in community-acquired pneumonia, who, when, and why. So this is very pertinent because we have been seeing a multitude of trials, a huge number of meta-analysis, and going back and forth as to really whether we need to uh, give steroids in patients with community-acquired pneumonia. Do we need to give it to everyone? How do we choose which patient to give it to? So community-acquired pneumonia, as we all know, is highly prevalent in our day-to-day practice. And we see a lot of morbidity and mortality, especially in patients who are elderly, who are immunocompromised, and who come with multiple chronic medical conditions. As per WHO, we know that lower respiratory tract infections form a leading infectious cause of mortality worldwide. And despite a lot of advancements in medical care, a lot of new antibiotics, and evolving ICU care, the outcomes haven't changed much. This has probably got to do with an aging population which we are dealing with, multiple comorbidities, and of course the MDR pathogens which are difficult to treat. So if we look about the pathophysiology of community-acquired pneumonia, the pathogens invade the lower respiratory tract, they infiltrate the alveoli and they replicate over there. The body's own defense mechanisms raise a local inflammatory response to deal with the pathogens and try to control the infection. However, often it goes out of proportion and we see systemic manifestations. The problem happens when this inflammation becomes dysregulated and a community-acquired pneumonia can progress to sepsis, ARDS, multi-organ failure, and death. And this is the main challenge why we need something more than just supportive care and antibiotics to deal with this major problem. So what could be the possibilities how corticosteroids might have an effect in community-acquired pneumonia? The proposed mechanisms are they can downregulate the cytokine production, thereby inhibiting the immune cell migration, reduce the inflammation at the lung level, and prevent respiratory failure in severe CAP. Some of them propose that the corticosteroids might act like they act in septic shock by regulating the adrenal response to infection. And there are certain proponents who say that it prevents a Jarisch-Herxheimer-like reaction when there is a microbial load and probably tries to reduce the amount of inflammation. However, the exact mechanism is still unclear. And there have been many, many studies which have been published over a period of years. And there were small studies of 20 to 40 to 60 patients. And probably this was the first trial which was published by a Spanish group, uh, including 120 patients. And they included patients with severe community-acquired pneumonia, whom they defined by the modified ATS criteria. And they selected patients with a CRP of more than 150 milligrams per liter. They divided the patient into a methylprednisolone group, 0.5 milligram per kg every 12 hours, and they compared it to the placebo. The primary outcome which they looked at was treatment failure. So it could be early treatment failure leading to shock, mechanical ventilation, or death, or it could be a late deterioration which happened beyond 72 hours. They looked at certain secondary outcomes like time to clinical stability, ICU and hospital length of stay, and in-hospital mortality. They showed that there was a significant improvement with corticosteroids in the methylprednisolone group. However, it is important to see that this benefit was predominantly driven by a reduction in late treatment failure. That too, they said the only thing which was different in the corticosteroid group was radiological progression of infiltrates. Now we really need to take this with a pinch of salt that just by reducing the radiological progression, does it really amount to improvement in the patient, or does it really account for reduction in treatment failure? They concluded that the acute use of methylprednisolone reduced the risk of treatment failure in patients with severe CAP who had a high inflammation. The Cochrane review, which was published in 2017, took all the randomized control trials which had been published so far, and they saw that corticosteroids definitely reduced death in severe community acquired pneumonia, but they did not have an impact when pneumonia was not severe. So this was important, and they found that this benefit was mainly restricted to adults, and you needed to treat around 18 patients to save one life. Apart from that, they reduced the clinical failure rates, they shortened the time to cure, a shorter length of stay, and lesser complications. As far as safety issues were concerned, obviously the corticosteroid group had hyperglycemia, and apart from that, there was no other serious adverse events. And to look closely at this, that although the mortality was less in the corticosteroid group, it did not make a difference if the pneumonia was not severe. So definitely it showed an impact only in severe CAP. Now, what I would like to focus on is the two main trials which have been published in the last 2 years. One is the ESCAPE trial, which was published from the US, and it included 586 adult patients. They gave steroids, that is methylprednisolone, from day 1 to day 7. However, they started a little bit late. This is in contrast to the next trial, which I'm going to talk about. And they tapered the steroid over a prolonged period of time, so over 20 days. And the primary outcome they looked at was 60 days all-cause mortality. And they not only looked at the short-term outcomes, but they also followed up the patients for 1 year. They defined severe CAP according to the ATS-IDSA criteria. Unfortunately, they found no difference in mortality, which was the primary outcome. They found no difference in the secondary outcomes in terms of ARDS progression, vasopressor requirement, organ dysfunction, mechanical ventilator free days, ICU or hospital length of stay. None of the subgroups showed a difference when methylprednisolone was given vis-a-vis placebo. There was a suggestion that there was a reduction in the median duration of mechanical ventilation, but they said that there was a low certainty of evidence. And even when they followed this patient for up to 1 year, methylprednisolone or steroid did not seem to make a difference. There was another study also which looked at long-term outcomes, and this was a study which was initially performed to compare prednisolone versus placebo for 7 days. The primary results, which they said at the end of 30 days, is prednisolone reduced the time to clinical stability and it reduced complications. But when they followed up these patients for 180 days, so at the end of 6 months, the results were completely different. It showed that in the steroid group, there was an increased risk for recurrent pneumonia, secondary infections, and more people became insulin dependent. So it is important to know that some short-term benefits may be overshadowed by long-term complications. So a lot of these trials, we probably need to see what happens to the patients at a later date. So this is the next study which has probably going to change our practice. And this was the Cape Cod study, which was published recently, and it was conducted in 31 French ICUs. And it compared hydrocortisone, which was given for 4 to 7 days. And depending upon the patient's clinical improvement, it was tapered over 8 to 14 days. It's important to understand that they gave these patients steroids within 24 hours. This is in contrast to what the American study did, that they included the patients up to 72 to 96 hours. So this becomes important to understand which steroid, when to give, and whom to give. They looked at the primary outcome of death at 28 days, and they had multiple secondary outcomes and safety outcomes. They included adult patients with severe CAP. Their inclusion criteria was a little bit different. So patients who required mechanical ventilation, high flow nasal oxygen with a PF ratio of less than 300 with an FiO2 of more than 0.5. Patients could be on NRBM with a PF ratio of less than 300 or a pneumonia severity illness score of more than 130. They excluded patients with a DNI order, influenza, as we all know that influenza patients probably have a contraindication for steroids, and patients with septic shock. They found a remarkable difference and a remarkable benefit that 28-day mortality was almost 50% reduced with hydrocortisone. They found an improvement in all the secondary outcomes with the steroid group. And as far as safety outcomes were concerned, apart from an increase in hyperglycemia, there was no increase in secondary infections, no increase in GI bleed. So they found that it was a win-win situation with hydrocortisone when you administer to patients with community-acquired pneumonia. Similarly, there was a lower incidence of intubation. There was a lower need for vasopressors secondarily. So hydrocortisone, if given early within 24 hours, reduced 28-day mortality in patients with severe CAP admitted to the ICU. So again, like we said, there have been a flurry of uh, meta-analysis. This was again published last year in the Clinical Infectious Diseases, and they also showed an all-cause mortality reduction, reduction in progression to ARDS, and shorter time to clinical severity. And there were two main independent predictive variables. Steroids had a lesser benefit in older patients, and they were more beneficial in patients who had higher WBC counts. They did not find a correlation with CRP in this study. And the series of meta-analysis continues. I would just like to focus on the one which was being published this year, and they have included the two latest trials. What is the need for so many meta-analysis? It's probably we are still not able to decide who, when, and why to give steroids, and there has been a difference in the guideline recommendations. American and British do not recommend giving steroids as opposed to European, Latin American, and South African who have certain conditional recommendations of giving steroids for community-acquired pneumonia. And they found that the all-cause mortality was reduced, the ICU and hospital length of stay was reduced, need for mechanical ventilation and vasopressors were reduced. And again, just hyperglycemia was the problem. When they did a subgroup analysis, they saw that hydrocortisone was the steroid which made the most difference. It worked only in severe community-acquired pneumonia. Dosing did not seem to make a difference. The duration of therapy in this meta-analysis did not have an impact, and younger age group seemed to benefit more. This was the other meta-analysis which again compared all the different kind of steroids and again went to show that it was only hydrocortisone which showed a dramatic uh, response as far as mechanical ventilation, risk of ARDS, risk of shock, hospital and ICU length of stay. So putting everything together, this is a latest focused update which addresses the issue that should corticosteroids be administered to patients with CAP. So they included all adult and pediatric patients with CAP, and they recommended administering corticosteroids to adult patients who were admitted with severe community-acquired pneumonia, but not for non-severe pneumonia. The dose suggested is 5 to 7 days of hydrocortisone, less than 400 milligrams or equivalent per day. It is important to define severe CAP. So whatever definitions, either the ATS, IDSA, or the definition which has been used by the latest Cape Cod trial, or the different pneumonia severity scores which we use in day-to-day practice. Now, what could be the difference why the ESCAPE and the Cape Cod trial had such divergent results? It could be the type of corticosteroid use, methylprednisolone versus hydrocortisone. The gender distribution was different. In the ESCAPE trial, 96% were men versus 69% in the Cape Cod group. So whether that has to do something with gender susceptibility to corticosteroids. The population was predominantly diabetic in the ESCAPE trial, so probably they did not fare very well with steroids. The timing of steroid was important. It was given earlier in the Cape Cod versus later in the ESCAPE trial. The duration again is important. It was a shorter duration, probably it works better. If you continue giving steroids for a prolonged period of time, maybe it has immunosuppressive effects, and the dose should be optimum. So this is a good algorithm that if you have a patient with community-acquired pneumonia, rule out a fungal infection or tuberculosis, rule out immunocompromised patients. If a patient has septic shock, the patient will automatically require stress dose of steroids. But if the patient fulfills the criteria of severe CAP and the patient has presented to you, early administration of steroids could make a difference. So to summarize, corticosteroids should be administered to adult patients in the ICU with severe community-acquired pneumonia. It is important to identify the severity, rule out the contraindications. If you have to give it early. The recommended dose should be less than 400 milligrams per day of hydrocortisone or equivalent. The effect on specific pathogens, immunocompromised, pregnant women and children are still unclear. It's important to look at long-term outcomes like secondary infections, neuropsychiatric issues, and neuromuscular weaknesses, which could be problems with steroids. Closely monitor for hyperglycemia because it comes with its set of problems. That becomes extremely important. Thank you very much for your attention.
Thank you, Dr. Swasti Sinha, for your wonderful and lucid presentation. Now I request